Good evening, everyone. My name is Lauren Yap. I am your National Chair for the Council on Advocacy. Thank you so much for taking time to join us at tonight's webinar and for participating in November's as this National Advocacy Month. So tonight we have a group of wonderful, esteemed panelists that I'm really excited to introduce you guys to. So we'll get right to it. Alrighty, so we will actually be hearing from one of our legislative coordinators tonight, Skylar. She is the legislative coordinator of Districts 4 and 5. She's currently a second-year dental student at East Carolina University. On behalf of Organized Dentistry, I am pleased to introduce Dr. Sharon Parsons, who is the Vice President of the Ohio Dental Association. Dr. Parsons is a general dentist and owner of Dental Associates in Columbus, Ohio. She's been practicing since 1981 when she graduated from the Ohio State College of Dentistry. She's been very involved in organized dentistry and is currently the president-elect of the Ohio Dental Association. She became very passionate about opioid addiction and prevention after her older son passed away due to an opioid overdose. She now speaks to dentists about opioid prescribing as well as addiction, and she has started a nonprofit, A Voice for Sean, with the purpose of educating and advocating for opioid addiction prevention. She is the recipient of a Lucy Hobbs Award for Humanitarianism and Ultradent's Icon of Dentistry Activism Award. On behalf of Oral Surgery, I am pleased to introduce Dr. Richard Gannon. So he is actually a clinical professor and a director of predoctoral education of the Department of OMFS at Boston University. He is a fellow of the American Association of Oral and Maxillofacial Surgeons, as well as a diplomat of the American Board of Oral and Maxillofacial Surgery. Our third panelist will be Dr. David Anderson, who will be speaking on behalf of health legislation. Dr. David Anderson is a director of oral and maxillofacial surgery from Roseman. He completed his oral and maxillofacial residency and a general surgery internship and MD degree from the State University of New York at Buffalo School of Medicine. He also holds the status of diplomat of the American Board of Oral and Maxillofacial Surgery. And he was in private practice for 18 years and is now the director of surgery at Roseman. In addition, we are also joined on tonight's webinar by Stephanie Follett and Keely O'Sullivan-Kurtz, two ASDA staff members. So without further ado, I'm going to turn it over to Skylar, who's going to review the issues and introduce our panelists.
All right, so in 2016, opioids, including prescription opioids, heroin, and fentanyl, killed more than 42,000 people in the United States. Deaths related to opioid abuse have increased drastically in recent years. 40% of those deaths involved the prescription pain reliever, according to the CDC. This October 2018, H.R. 6, which is the Support for Patients and Communities Act, was actually signed into law, and more than 140 bills were moved through Congress before H.R. 6 was adopted. Another interesting statistic from this slide is that the prescription opioid misuse contributes to approximately $78.5 billion of the total economic burden. So moving on to ASDA's B13 policy. So this policy was adopted at the 2018 House of Delegates meeting. And this policy advocates for dental students to provide education and resources to help students address the opioid epidemic. Dental schools are incorporating education on safe prescribing practices and identifying the signs of addiction into curriculum, but the education is not currently standardized. So this is the resulting policy for our opioid. And what has ASDA done? So this slide will focus more on our lobbying efforts. So on April 10th of 2018, we had more than 500 ASDA members that lobbied Congress on this issue. So this new law that has been passed aligns with the principles that were advocated for, and it provides a new round of grants for prescribers to learn about the best pain management practices with the minimal use of opioids. It also provides a series of grants and expanded agency authorities to help states improve their prescription drug monitoring programs. The emphasis would be on making those systems more efficient, more reliable, and easier to use, and enabling the information to be shared between states. It requires the Food and Drug Administration, the FDA, to develop evidence-based opioid analgesic prescribing guidelines for indication-specific treatment of acute pain where such guidelines do not exist. And it expands the National Institutes of Health's authority to rapidly divert funds for high-impact research in response to public health threats, such as fostering the development of non-narcotic alternatives to opioid pain relievers. We are now going to move into Dr. Sharon Parsons' portion of the presentation.
Okay. All right. I'm just waiting for this slide to advance. Okay. So I was given two questions tonight. The first was what science should dentists consider when prescribing? And I think one thing, especially people in my generation, if this slide will go like it's supposed to, is we never learned anything about addiction. So I really think it's important that everyone become experts in addiction. Because I'm going to give you a few facts that you may not have known, and you in school maybe you do know about this. So patients between the ages of 13 and 26 are 5 times more likely to become addicted if exposed to an opioid, and that's because the prefrontal cortex is still forming. So instead of just thinking about that and throwing out a fact, I want you to really think about that age group. So that's middle school, high school, and college sports. And on our end, that's wisdom teeth. And you hear a lot of parents, because I'm, exposed to a lot of parent groups that have lost children, and they will say it all started when he got his wisdom teeth out. He'd never had an opiate before. So we really need to be aware of this. So of all the people with addiction problems, 96.5 started substance use before age 21. That's right in that tender age group. And genetics accounts for 40 to 70% of the risk. So, if you're genetically predisposed to addiction and you're in that tender age group and you're given an opioid, chances are pretty good that you may become addicted. With my son, he hurt himself. He went riding dirt bikes when he wasn't supposed to during finals. And he didn't want me to know because I told him not to go. So he didn't go to the ER. He didn't go to urgent care. A guy living in the house off campus beside him handed him some OxyContin and said, "Here, take these, you'll be okay." And apparently he was, and apparently he liked it. And 4 pills started it all. Now, did 4 pills get him addicted? Probably not. But 4 pills gave him enough of a taste that he knew he wanted to go back for more. And I hear people say, well, I've been prescribing for years. I've never gotten anyone addicted. People are not calling me back asking for more. Well, you know what? They're not going to. They're a lot smarter than that, and they're a lot more embarrassed. They're not going to call you up. They're going to go elsewhere and get that. you're never going to know that you caused that patient a problem. So there are some alternatives. This is a study that talks about combining ibuprofen and acetaminophen, not together, one after the other. Don't let one wear off before you start the next. And really, it is more effective for third molar extractions than an opioid. So for acute pain. Another thing that is pretty new right now is Exparel. So it is a local anesthetic that is infiltrated after the extraction is done. It can't be used as the anesthetic agent to do the extraction. It's given only on the buccal, infiltrating afterwards. And it's still, I guess I'm going to say it's still in the testing phases. I don't know that the jury's out yet on this. Someone I know in Cleveland who's been working with it says it lasts at least 48 hours and gets them through that first hard phase. So I guess we'll watch and we'll see how that works. And then in October, and you were talking about some other things kind of relating to this, the ADA passed their opioid policy. So resolved that the ADA supports mandatory continuing education. That was the big sticking point in prescribing opioids and other controlled substances, with an emphasis on preventing drug overdoses, chemical dependency, and diversion. Any such mandatory CE requirements should provide for continuing education credit that will be acceptable for both DEA registration and state dental board requirements. Provide for coursework tailored to the specific needs of dentists and dental practice. Include a phase-in period to allow affected dentists a reasonable period of time to reach compliance, and be it further resolved that the ADA supports statutory limits on opioid dosage and duration of no more than 7 days for the treatment of acute pain, consistent with the CDC evidence-based guidelines, and be it further resolved that the ADA supports improving the quality, integrity, and the interoperability of state prescription drug monitoring programs. So that was kind of a big one. If you remember at Lobby Day, it was pretty contentious. And I was happy to see that at the House of Delegates, it was on the consent calendar. So we came a long way. Okay.
Thank you, Dr. Parsons. So for individuals who'd like to ask their questions, like we mentioned in the beginning, there will be a Q&A after each panelist, and you are able to submit your questions to the control panel to your right, and we'll be taking questions in the order that they are submitted. So, our first question is, when was the ADA policy adopted?
Just a couple weeks ago, in October in Hawaii at the ADA House of Delegates.
And Dr. Parsons, do you have any recommendations on how we can make the policy stronger?
Well, I think over time that 7 day is going to decrease. That's my personal feeling. I think we had to reach we had to meet somewhere in the middle between people who wanted to prescribe like they'd always prescribed and people who didn't want there to be any opioids. So I think this was a first middle ground. My guess is that it will tighten up in the future.
Our next question is, you mentioned that 30 to 70% of opioid addiction risk comes from genetics. Could you tell us some other factors?
Well, addiction risk. Like I said, the age group, and I think I don't know if I'm going to say necessarily lifestyle, but I think if you are in that tender age group and you hang around with a lot of people and they experiment a lot, you're at least likely to try it. Now, I think genetics comes into play when 10 people try something and one becomes addicted. That's when genetics really takes its turn. Just like alcoholism, a lot of us I can go out and I can drink socially, and I'm not an alcoholic, but I have some friends who cannot drink, and genetics plays a part. So I think we're going to find other things over time as we learn more about addiction. I certainly wish that I had known more. Maybe I could have done more to prevent this from happening with my son. Right now, there's not a good answer as far as treatment. So, our best bet is to try to create fewer future addicts.
And do you know of any other organizations that have come out with similar policies to the ADA's?
As far as I know, we're the first one. I presented in Columbus. I was asked to present to the Ohio Association of Political Scientists and Economists. I got to tell you, that was a dry group. But anyway, they hadn't ever heard of a group having something like this, and they were all really excited about it. So I think it's really good for us as a profession to be on the front end of it and to say we support this. I mean, I think the boards are going to mandate it anyway. I know in Ohio they are, and Ohio has its own opioid policy, but I think it's really important that we get out there and say that we support it. I know, being on the other side, I wear a couple of different hats. So wearing the mom hat when I am with groups of parents who have lost children, they're very angry, and they are watching what the medical and dental profession do, much more than you would ever guess. So I think it's really, really important that we take this seriously and we come out saying that we support this and try to turn it around.
I couldn't agree more. Our next question is, what are some signs that might suggest to a dentist that a patient is asking for opioids that they are coming from like an addiction?
Well, a lot of times, their eyes give it away. There aren't many things that you're going to do as a general dentist that you would really, really need to give an opioid. Now, sometimes endo, some, oral surgery sometimes, but, as I showed you, acute pain can be controlled with ibuprofen and acetaminophen. So, especially when they name their drug, that's a dead giveaway. Or if they call you on the weekend, I would get calls. I have more than one dentist in my practice. So one thing they like to do is wait until they know that no one's in the office. And then they will call and they'll say, oh, Dr. Parsons, I saw your partner, Dr. So-and-so, yesterday, and he took a tooth out, and I'm in terrible pain. Or, they did a filling, and oh my gosh, my tooth is throbbing. I really need you to call something in for me. Now, my typical thing when they say that, when they just had a filling done and their tooth is throbbing, I say, gosh, it sounds like you probably need a root canal. Tell you what, I'll meet you at the office in 15 minutes. Well, usually it's just click on the other end. Very seldom do I get taken up on that. But yeah, when they're asking and they have a drug of choice, that's a big red flag.
Okay. Well, thank you, Dr. Parsons. I'm going to hand it over to Skylar to introduce our next panelist, but we will come back to any questions if we have time at the end.
Sure.
All right, so we will move on to opioids in oral surgery, and I would just like to introduce Dr. David Anderson.
Hi, everyone. As was mentioned, my name is David Anderson, and I'd like to thank everyone for the opportunity to join in on this discussion in combating the opioid epidemic. And for the last few years, I've really had a growing interest in learning about this opioid crisis and how we can be part of the solution. As I've done literature searches, I've found that dental professionals account for approximately 12% of all immediate release opioid prescriptions, ranking them second only to primary care physicians for prescribing immediate release opioids. So I think as dental professionals, we have been part of the problem, but now we can be part of the solution as well. One study estimated that each year more than 1 million opioid pills prescribed to patients after the extraction of third molars remained unused. So I think oral surgeons especially have overprescribed in the past, and there's a lot of leftover pills following the oral surgical procedure. That is something that we can change tomorrow, and it just requires some education. What are oral surgeons doing? Well, the American Association of Oral and Maxillofacial Surgeons came out in the last couple of years with 2 white papers, one on prescription drug abuse and prevention, and the other one's called Opioid Prescribing, Acute and Postoperative Pain Management. And they list some guidelines that I believe can help be part of the solution. One of them is to adhere to your prescription drug monitoring programs. Here in Utah, they passed legislation requiring all providers to check the Utah Controlled Substance Database prior to writing out a prescription for controlled substances. And when you have to go to your computer, check the database, and see if your patient has had any other prescriptions written for them in the last few days or from another provider, it really makes you stop and think, does this patient really need an opioid prescription? I think it's really helped Utah lower their prescription writing for opioids. When we look up that patient, it reports the controlled substance that was prescribed, the provider who wrote it, and the amount prescribed. And I think that's really helpful to know. One, I think it helps in discussions with our medical colleagues in improving continuity of care and helping to treat the whole patient. We don't double prescribe, and we can arrange with our medical colleagues to have one prescriber for this patient for their multiple issues. Another point on the Amos's white paper is continuing education. And Amos has, in conjunction with the National Institute on Drug Abuse, developed an educational course to help talk to adolescents about substance use and abuse, which is helpful. It's also, in conjunction with SAMHSA, developed a training program for safe opioid prescribing and acute dental pain, which oral surgeons or any dentist can go through. It states that CE is best managed at the state level and to be appropriate to other CE requirements and be customized so that it's relevant to each type of prescribing situation. Here in Utah, before we renew our license, we have to do continuing education on opiate prescribing. Now, the other white paper in prescribing guidelines goes along with Dr. Parsons' alternative prescribing, and it recommends that we use non-steroidals rather than opioids as a first-line therapy to manage a patient's acute and postoperative pain. And what I found is that in the literature over the last several years, there are several papers stating that when you combine ibuprofen and acetaminophen for acute pain management, it works as well or better than an opioid. And I think it's going to take not only education on our parts, but us educating our patients as to the evidence-based dentistry and how that will help with our postoperative pain management. And basically, to summarize, I think dental professionals are prescribing a large number of immediate release opioids, but through programs such as the Controlled Substance Database, continuing education, and adhering to the guidelines put out by the ADA and American Association of Oral and Maxillofacial Surgeons, that we can decrease the number we're prescribing and become part of the solution.
Thank you, Dr. Anderson. We really appreciate your insight. So we will be taking questions for Dr. Anderson. Like I mentioned, you can type in your question on the side of the control panel, and we will answer the questions in the order that they are submitted. Dr. Anderson, our first question is, where can we access the AAOMS white paper that you referenced?
Yeah, both of those papers are found on the AAOMS's website.
Okay. Thank you.
While I'm waiting for the next question, it's been a stark contrast from being in private practice for 18 years prior to coming to the dental school. And the dental school here at Roseman, we try to follow that guideline of as first-line therapy, we use ibuprofen and acetaminophen. And it's amazing how few people we need to prescribe an opioid to. It works well, and people don't ask for anything else. So I think as we get in the habit of using opioids as a second line, we can improve that prescribing.
What would you say, Dr. Anderson, if you had a patient who just insisted that like a non-opioid medication, the combined effect of the two medications, that's just not going to be enough for them?
Yeah, that happens. And I think prescribing should be done on a patient-by-patient basis, case-by-case basis. And there's always exceptions to every guideline. And you need to treat your patient the best way possible. And there are some instances where I would prescribe an opioid. But as a general guideline, I would stick to the first-line therapy.
What would you say is the greatest barrier for dentists in following these new prescription guidelines?
Well, like the last question, I think there's some pressure from patients. There's education that needs to be done. And I think as we become more familiar with the randomized controlled trials that have been done, we'll be more confident to educate our patients to those guidelines. So I think it's education.
Do you think that it's a possibility in the future that opioid use in oral surgery as well as dentistry could be banned altogether?
No, I don't think so. I think there's a place for opioid therapy in postoperative pain management. And again, it's patient by patient and procedure based. And as you treat your whole patient, I think you can come to a good balance between opioids and non-opioids.
And I have a question. Our next question is, how does medicine differ in their approach to opioid prescribing?
So I think at least here in Utah, I've noticed that the physicians have caught on a little quicker. And I think as they treat patients in the hospital setting, they have more exposure to the evidence, whereas dentists in their private offices maybe have difficulty with the latest studies and education needed. And I think it seems like they've been quicker to try to reduce the number of opioids, and I think we're catching on, but we have a little work to do.
Thank you. Let's see. Alrighty, so that's actually all the time we have with Dr. Anderson. So like I mentioned previously, if we have time at the end, we will take more questions. But for now, I'm going to hand it off to Skylar, who will introduce our final panelists.
All right, so here to speak on opioids and health legislation is Dr. Richard Gannon, Clinical Professor, Boston University.
Thank you, Skylar. I'd like to welcome all for listening into the webinar this evening. I have been given the opportunity to present health legislation as related to the Commonwealth of Massachusetts, and I appreciate having this opportunity to do that. Once I can get the slide to move forward. As part of the working toward the education of dental students and residents, the Governor's Dental Education Working Group on Prescription Drug Misuse was formed and tasked with developing dental education core competencies for the prevention and management of prescription drug misuse, which was put forward in January of 2016. The working group was composed of the Massachusetts Department of Public Health, Massachusetts Dental Society, and the 3 dental schools located in the state of Massachusetts, which all are in Boston, the city of Boston, excuse me. So Boston University, Henry M. Goldman School of Dental Medicine, the Harvard School of Dental Medicine, and Tufts University School of Dental Medicine. And the competencies were developed with the idea in which a patient with pain would require a prescription for an analgesic medication in which potential misuse can occur. The goal is to provide future prescribers with the knowledge and skills to competently prevent prescription medication misuse. Now, the core competencies are divided into primary, secondary, and tertiary prevention domains. The primary domain relates to the evaluation of patients' pain and developing the appropriate differential diagnosis. It's also to evaluate the patient for risk of substance use disorder, to identify pharmacological, whether opioid or non-opioid, and non-pharmacological treatment for acute or chronic pain, along with risk and benefits of treatment provided. And finally, the proper storing while in use and disposal of any unused medications. The secondary domain relates to the ability to appropriately refer patients for consultation and collaboration with their primary care physician or other care providers. It provides for the practice of patient-centered, evidence-based pain management, safe prescribing, and the ability to recognize patients displaying signs of aberrant prescription behaviors. And the tertiary domain relates to the use of screening instruments to determine the at-risk patient, eliminate the stigma associated with substance misuse, viewing it as more as a disease, and develop an interprofessional education engaged in collaborative training. The core competencies allows for the schools in Boston to tailor their competencies to their own curriculum development. I will now present some of Massachusetts legislation as it relates to the dental practitioner. As already has been described, the Prescription Monitoring Plan, or PMP, is used to track statewide Schedules 2 through 5 prescriptions. In Massachusetts, it's termed MassPat, which stands for Massachusetts Prescription Awareness Tool. So in March of 2016, legislation was passed that produced the following. Effective October 15, 2016, all prescribers are required to check the MassPat each time a Schedule 2 or 3 opioid is prescribed, or when a benzodiazepine or the Department of Public Health designated scheduled drug for the first time. In August of 2018, it is now required that prescribers utilize the MassPat each time a prescription for a benzodiazepine is issued. Now, there's a limit on opioid prescriptions, and Massachusetts was the first state that incorporated a 7-day limit on initial opioid prescriptions. Now, there are other states that may have 3 days, 5 days, but in Massachusetts, we have a 7-day limit on initial opioid prescriptions for adults and a 7-day limit on all opioid prescriptions for minors. However, there are some instances in which a practitioner could prescribe more, and I'll go into them in just a second. It also requires that physicians discuss with the parent or guardian of the minor that the risk associated with the opioid use and reason why the prescription is necessary. If in the medical judgment of practitioner, a more than a 7-day supply of an opioid is required to treat the adult or minor patient's acute condition or necessary treatment of chronic pain management, such as associated with cancer or pain experienced while the patient is in palliative care, then a practitioner may issue a prescription for a quantity needed to treat such a condition. The condition triggering that prescription for longer than 7 days needs to be documented in the patient's record, and the practitioner shall indicate that a non-opioid alternative was not appropriate to address the medical condition. It also requires physicians and pharmacies to provide information about the dangers of opioid addiction when an opioid is dispensed. The law also provides for liability protection for anyone who administers naloxone to someone suspected of opioid overdose, and it requires additional training for professional students. So not only in dentistry, but also medicine, where core competencies have been developed. And practitioners about safe prescribing practices in substance abuse, as was stated by Dr. Anderson in the state of Utah, is also in the state of Massachusetts. When it comes to relicensure every 2 years in Massachusetts, the applicant has needed to complete a CE course in relation to safe prescribing practices in substance abuse. It also allows for the patient to fill a lesser amount of opioid prescription. So you are required, when you're giving an opioid prescription to the patient, discuss why you're giving the opioid to the patient, and also let them know that they have the right to ask for a less amount than you are prescribing for them. Now, in that 2016 law that passed, the remainder of the prescription would become void, and the pharmacist would notify the doctor the amount that was dispensed. That's since changed a little in 2018. I'll talk about that when we get to the CARE Act. But on our prescriptions, we need to put partial fill upon patient request. The law also allowed for patients to voluntarily opt out of being prescribed opioid medications, but they can also opt back in. They can revoke the directive at any time, and that can either be orally or written. It also created a screening mechanism for schools to use in identifying students that may be at risk for addiction, and incorporates education about opioid addiction into the schools, and sometimes really associated with annual high school sports training in regards to the concussion protocol. It also established a 5-year stewardship program in which drug manufacturers must participate to aid in the safe collection and disposal of unneeded prescription medications. And finally, patients who enter an acute hospital ER or satellite emergency facility suffering from an opioid overdose shall receive a substance abuse evaluation within 24 hours. Now, an Act for Prevention and Access to Appropriate Care and Treatment of Addiction, or the CARE Act, was signed into law in August of 2018. Some of the highlights include the following. It basically increased the access to naloxone by directing the Department of Public Health to issue a statewide standing order that would authorize every pharmacy in Massachusetts to dispense naloxone. There would be liability protection, which would encourage broader use of naloxone by guaranteeing that practitioners who prescribe naloxone and pharmacies who dispense it in good faith would be protected from any criminal or civil liability, and it expands the range of medical professionals authorized to perform substance abuse evaluations. It requires that emergency departments affirmatively connect patients to the appropriate level of care prior to discharge, and revises the Massachusetts current partial fill by allowing patients to receive a portion of their full opioid prescription without invalidating the remainder. So if somebody if you wrote a prescription for 20, they filled 10, they could go back and get the other 10 tablets, but they must return to the same pharmacy, and it has to occur within 30 days that the prescription was filled. It also mandates by 2020, all prescribers must convert to a secure electronic prescription when prescribing a controlled substance. This would help with fraud and diversion and allow for better tracking. And it supports the development of an approved drug formulary to regulate use of opioids in treating workplace injuries. It creates a commission for recommendations on appropriate prescribing practices for the most common oral and advanced dental procedures, which includes recommendations on approving the use of standardized prepackaged doses of commonly issued prescriptions to reduce the likelihood of overprescribing. It also creates a commission that will review and recommend non-opioid as well as non-pharmacological strategies. And the commission would be tasked with developing a plan in which insurers would be able to provide adequate insurance coverage and also provide access to these alternative pain management strategies. Now, this is only a partial summary of some of the Massachusetts legislation. Recently, the Support for Patients and Communities Act, the federal mandate, came down in October 2018, which was signed into law. So just be aware that things are not only being done on the state, local level, it's also being done at the federal level. So the question is, what's the future state or federal legislation related to opioids? As was presented, I think, very well throughout this webinar, was that using the prescription monitoring program and physician education really has decreased the amount of opioid prescriptions and the amount of opioids that are being prescribed now. As was stated previously by Dr. Parsons and Dr. Anderson, general dental procedures that are performed usually do not require opioids. However, on certain situations, there may be a requirement on certain occasions. And when they are needed, the appropriate medication, dose, and the total amount to be prescribed should be appropriate. This avoids any leftover medication and prevents from any diversion where somebody can get a hold of these medications and use them for a purpose they're not intended for. And I thought that was really stated, and I really wanted to drive this point home, is not only the education of the physician, but education of our patients. Not only the opioid misuse addiction to the medications, but it is also important to educate them in the storage, disposal, as well as in regards to pain and pain management, letting them know that with the combination of nonsteroidal anti-inflammatories and acetaminophen should take care of most dental procedure pain. Other things that we can look at is development of more non-opioid and non-pharmacological means for treatment of pain, especially chronic pain. And a lot of these things are trying to prevent somebody from going into misuse and possibly addiction, which is good, but we also got to think about those patients that already suffer from the disease of the addiction. So legislation needs to be developed in regards to finding funding for hospital beds for recovery and treatment for these patients. And with that, I'd probably taken up more than my time. I will go to any questions and answers. But again, thank you for letting me participating in this webinar.
Well, we want to thank you, Dr. DiNcenzo, for enlightening us and giving us just a little bit more information about the legislation that's taking place, especially in Massachusetts. So we will now take questions for Dr. DiNcenzo. One question that we have is, you mentioned benzodiazepams. Why is that also included in conjunction with the opioids?
That's a very good question. You'll find that what they found out with the studies with overdoses, you'll usually see a combination of opioids along with benzodiazepams. So they are sometimes used in combination, and you have the additive CNS depressant effect. So they're also brought into the picture.
Are there some states that already have a mandatory electronic prescription regulation like New York?
So you kind of answered the question. That is the one that I know of as of New York, and they've had it probably, and I can't be quoted on this, but like at least for the last year, I think. And I do think this is what we're going to be going to in the future. Obviously, Massachusetts is looking at it. It does take some time to implement, though.
You mentioned that the CARE Act expands the range of medical professionals authorized to perform substance abuse evaluations. Would this include dentists?
It's a very good question. This is more in regards to somebody in the emergency room and treating them. One of the things we are teaching our students here is basically evaluation of the at-risk patient. And we have certain things that we go through, like the SBIRT, and with that, try to find out those patients that may be at risk. And then the question is, how do you then refer them to treatment after doing the brief interventions.
Who are the other stakeholders to work with to get legislation passed in the state?
So if you're asking, like, who would you go to as either a student or somebody from the school, I would say your best group to go through is going to be through your state dental society. They usually have liaisons to the legislature. In numbers, things get done. In Massachusetts, we have a day on the Hill where we go and we meet our legislators. And also you can go grassroots. You can go into your hometowns and state that you're at. Because I just recently spoke with one of our state reps. They hold office hours. They're willing to talk to you. So you need to come with an idea what the situation is. You don't have to have the answers, but you need to advocate. And the more people that advocate, the better chance things are going to get heard and the better way things are going to get done.
Alrighty. I apologize to any of our listeners if you're hearing a little bit of an echo. Our next question is, can you give us an example of some of the brief interventions that you've mentioned in regards to screening the at-risk patient?
So if you have somebody that is, I'm going to pick up both of the phone, okay? If you have somebody that you're going through a history and you notice that they're at risk, so you may have a conversation with them saying, do you know that this type of behavior is detrimental to either your medical health or trauma related, those type of things. And then you have to see if that patient is willing to then proceed on to go for treatment. So those are some of the brief interventions that you're talking about. We could spend hours on that, which we don't have.
And I think our final question for your section is there any current push for a federal prescription monitoring program that would include prescriptions given to patients in every state?
So that's a good question. So let me just see if I'm reading this correctly. So I guess you're not saying would every state have to have a prescription monitoring plan, but would you be able to have access to all the other states that are involved? It's a good question. I don't know exactly if it's from a federal level, where that's coming down. I can tell you the state of Massachusetts participates with 31 states along with the District of Columbia. So it's one of those, it's more along the lines of, can these monitoring plans communicate with one another? And it may have to go to a higher level to make all this happen.
Thank you, Dr. DiNincenzo. So the next few minutes, we will be taking questions for any and all of our panelists before we turn to Skylar one last time. How do you decide when an ibuprofen acetaminophen combo will be sufficient as a post-surgical analgesic versus when you should prescribe something stronger?
Well, I can attempt to answer that. What we've done is we just as a general policy prescribe the ibuprofen acetaminophen combo first, and if they fail on that, then we add an opioid to it. And that way we can get a feel for our patient and how they're going to respond to the first line without introducing the opioid at first, and then only adding it as a second line.
And I'm in agreement. Sorry, I'm in agreement with that also. Sometimes when it does come down to where you think you're going to have to prescribe an opioid, the limit may be like 2 days, and also keeping your nonsteroidal around the clock for the first 48 hours, and then the opioid runs out after 2 days. But it depends on, again, you have to gauge your patient and your procedure, what needs to be done, but majority of the time, the combination is going to be sufficient. And if they fail, you would go to the opioid.
Thank you. Like I mentioned previously, this time is basically a free-for-all. Any questions can be submitted for any or for all of our panelists to answer. Alrighty, our next question is, how will interprofessional cooperation come into play with patients who are seeking opioids from multiple specialties? For instance, a patient that may go to their dentist or a physician for an opioid, or both.
So the question would be, are you saying if it's being treated for the same symptoms and they're seeking medications from a physician and a dentist, one of the things you'd be able to do is by going through your prescription monitoring program to see what medications have been prescribed for your patient, and you'll know who's prescribing that for them. And that may lead you to figure it out, this patient is getting the medications from someone else. Now, you can look at interprofessional a little bit differently. Like if you have a patient that's being treated for a situation that's already in a substance misuse situation and is being treated by a physician for that, or is on a contract for pain medications, then you should be in contact with them, and that person may take over that patient's pain management since they're already contracted to do so. I don't know if that actually answers the question, but
I think it does. Dr. Parsons, Dr. Anderson, do you have anything to add?
I don't think so. I appreciate you involving me, and thank you very much.
Yeah, I'd just like to add, I think it's a good opportunity for dental professionals to maybe expand on these spirit items and be a first-line provider who maybe has a questionnaire or asks our patients about substance abuse, alcohol abuse. There's CAGE questionnaires and the NIDA quick screen that we can incorporate into our practices that give us an idea of who might be at risk and who we can perhaps send them on to.
Thank
I
you.
appreciate being involved.
Our next question is, what should dentists and dental students be advocating for this year regarding opioids, both at their state and their national lobby days?
Well, if your state does not have an opioid policy, then I really think that they should. We just got our national opioid policy. So, you know, maybe this year something else takes center stage.
Anything to add, Dr. DiNincenzo or Dr. Anderson?
as I had pointed out during the presentation, again, like funding for maybe when you start thinking about the alternatives, medications in regards to like non-opioids, the development of those, funding for the patients who are already associated with the disease. And then if you're at the state level, you know, make sure you have a prescription monitoring plan. And then are you thinking about maybe a limit on the amount of opioids for a period of time? Those are things you may want to think about. And those are some of the things I would think about. But I do want to point out what Dr. Anderson said about the NIDA quick screen. That's a very good, easy, simple thing to follow through to find out somebody who's at risk.
Dr. Anderson, anything to add?
No, I think that's been well stated. Thanks.
Wonderful. Well, thank you so much to all of our panelists. I'm going to actually turn it over to Skylar, who's going to discuss a little bit more about how we as dental students can become a little bit more involved.
All right, thank you, Lauren. I'm going to see if I can get a hold of this mouse here. Okay. All right, there we go. So November is ASDA's Advocacy Month, and we just want to emphasize that there are multiple ways to participate in Advocacy Month, both on the chapter and the individual levels. So one of the first ways is the Populous Chapter Competition, and with this, the chapter that receives the most social media likes on their advocacy event post will win the contest. So chapters can post a photo from their advocacy event on the Instagram and then include a short statement describing the event and then tag @dentalstudents. Also use the hashtags like advocacy and #ASDAPopulous, and then make sure that the page is also set to public. The Muller Bear Initiative. So despite Muller Bear being very busy in 2017, Muller Bear has made a way across the nation to chapters. So when chapters receive the bear, they take a photo with the bear with the university logo or landmark, and then they film a short social media video with the bear, naming one thing that your chapter has done to advance advocacy efforts this past year, and then post the video to Instagram and use the hashtag #AdvocacyBear and #AsdaAdvocacy, and also tag @dentalstudents. And then the bear is mailed by that chapter to the next chapter by the established deadline. But this year's deadline was earlier in October to sign up for the bear, but just don't forget that there's always next year. And then keep an eye out for those posts from chapters who are hosting the Muller Bear on their social media pages, as well as ASDA's. And then one last thing is that you can also hold various advocacy events throughout the month of November at your individual chapters as well. There are also ways to participate on the individual level, and one is the political cartoon competition. The deadline for this is actually November 16th, which is this Friday, but members can submit a political cartoon that features their favorite advocacy-related pun. And then also just make sure that you can read some grassroots resources, such as the Advocacy Handbook and the How-To Guide that you can find on asdanet.org. And I believe that wraps that up, so I will turn it back over to Lauren.
If we didn't get a chance to answer any of your questions this evening, I know it was a little bit of a shorter panel and we had so much great information. Please feel free to contact us with any questions at advocacy@asdanet.org, and we can always pass them on to our panelists. And before I kind of say goodnight to everybody, I'd like to take time to thank Dr. Parsons, Dr. DiNincenzo, and Dr. Anderson for joining us on tonight's webinar, for providing us with insight on the different kind of factors of dentistry that are going into combating the opioid epidemic. I know many of us dental students that attended Lobby Day last year, heard the different stories. We heard from Dr. Parsons and we felt compelled to act, and we wanted to know what more we could do. And that's what came to be the objective of this webinar, is we wanted to have the most up-to-date information and find out and hear from the experts from the different fields of how we're all working together against this. So thank you very much for your time, and thank you everybody for tuning in, and we hope to hear from you if you have any questions. Good night.